Okay, so today I'm going to be demonstrating a full head-to-toe physical assessment. So to begin, we're just going to ask the patient his name.
Nicholas.
Okay, and how old are you?
22.
Okay. Do you have any relevant past medical history?
No.
No. Okay. Any family history of illness?
Just a heart attack and stroke for both my mom and my dad's side.
Okay. And are you having any pain today?
No.
No. Okay. Any allergies to anything?
No.
Do you take any medications currently?
I just take Protonix for heartburn.
Okay. Do you smoke or drink?
Nope.
Okay. Alrighty. So that's basically a short interview of the patient. And moving on. So we're going to go on to a general survey and looking at skin. So in looking at this patient, he looks relatively healthy. His level of consciousness is fine. He was able to tell me his name, able to tell me, why we were here, what we were doing. He's not in any signs of distress. How tall are you?
5'11".
Okay. And what do you weigh?
190.
Okay. And he has good personal hygiene. I mean, I don't see any issues there. He's not unkempt. We can go ahead and assess some vitals while we're at it. So I'm going to begin with the heart rate. And I can also feel his pulse. Kind of compare the two. I can assess his temperature. So this would go in his mouth if it were clean. And we can do that. Go under the tongue and it would beep when it's done. You can look at respiration, see how many times a minute he's breathing. He appears to be calm, about 16 breaths a minute. And then I can also take his blood pressure. You can relax your arm. We are at 130/80, so that's an okay blood pressure. Not bad. Okay. And then from there, we can also do like a skin assessment. So I can look at his skin. I can feel his skin. It's warm. It's dry. It's not moist like he's claiming or anything. He's not abnormally pale. There's no pallor. He's not cyanotic. I can look at his eyes. I can open your mouth for me. So I can look at his mucous membranes and see that he is not cyanotic. I can also look at for rashes. Have you had any itching recently? No. Okay, so pretty normal skin assessment. I can also look and feel for edema of the skin and the extremities. I can feel the legs as well. Also looking at that skin there. I can look at his hair. I can look and see that it's clean. It's well taken care of. No infestations. I can look at his nails. I can look at capillary refill. Nails look fine. Capillary refill is great in all of those. It's brisk. It's within 2 to 3 seconds. There's no sluggishness there, indicating good, adequate blood flow. No clubbing in the nails, nothing like that either. So, that kind of concludes my skin assessment. And on to head, eyes, ears, nose, and throat. So I can look at his head. I can see that it's symmetrical. Both sides of his face, are symmetrical. I can also palpate his scalp and his head for any tenderness. Any tenderness with that? No? Okay, so I palpated both sides and there's no tenderness. It's symmetrical on both sides. I don't feel any lesions, anything like that. No edema. I can also see, I can palpate his temporal arteries, make sure those are good. I feel good, pulsation there. I can palpate his masseter muscle with his jaw. So I'm just kind of open, kind of clench his jaw. Okay. So he has a good masseter muscle. I don't feel any inflammation with that or anything like that. I can also palpate lymph nodes, so I can start kind of at the base of the neck, palpate down, palpating lymph nodes. He looks like he's in distress, but he is not. And those all feel great. So I could also palpate his sinuses to go along with the head assessment. Yeah. Any tenderness with that? No? Okay. So, normal head assessment. I can then assess his eyes. So I can start with using my pen light. So I can use my pen light to check pupil size. So he's going to look straight ahead at me. And his pupils do constrict with that, which is good. We want that to happen. Pupil size should be around 4 millimeters, and his pupil size is fine. It's pupil dilated and constricted, respectively. So then I can also check and look with my ophthalmoscope. I can look at the arteries and the veins and the eye. Okay, so what I'm going to do is just look straight at me. This is a kind of dark room anyway, so I'm going to go ahead and look. Okay, and so those look normal. No issues there. And then I already assessed that he has, preload pupils equal, round, and reactive to light. So then we can go ahead and assess his visual acuity. So to do that, we are going to, he's going to look at me, and first he's going to follow my eyes. Or follow my finger, I'm sorry. He's going to follow my finger with his eyes. Just checking those 6 cardinal points. Okay. And so his eyes, they move evenly, no issues with eye movement. We can also have him cover, look straight ahead for me at that chart on the wall. And you're going to cover one of your eyes for me. Okay, now can you read the letters on that chart of the smallest line? Okay, and then can you cover the other eye and do the same exact thing? Okay, so he has good vision. He has 20/20 vision because he was able to read the line that read 20. So, good, adequate vision. No problems there. And then we can also check his visual fields. So he's going to cover one of his eyes again for me. And you're going to tell me how many fingers I have. 2. Okay, cover the other eye, and let's do the same thing here. Okay, and so we're also going to do this one more time. So cover the other eye. Start with just start with one eye. Okay. Okay, and then you're going to cover the other eye and do it again. 2. Okay, so he can see. Good visual acuity there. And I don't see any drainage from the eyes. I don't see any abnormalities there. No, issues with the iris. The sclera, his sclera are very white, so they're not reddened at all. I don't suspect any scleral issues. So we can then move on to assessing the ears. I'm going to go ahead and attach my otoscope here. So I'm going to pull up and back on the pinna of the ear. Sufficient earwax. I'm going to check the other side.
Sufficient. No.
Yes. And you've got earwax in that ear too. Not an abnormal, unhealthy amount, but there is earwax present. It's okay. For the purposes of this video, it's okay. Okay, so I'm also looking at the ears for any redness, any perforations. Both of his tympanic membranes in his ear were shiny. There were no perforations, anything like that. Just earwax is the only thing that I saw. There's also no swelling of the tympanic membrane, which is great. So, in assessing his hearing more, we can do the whisper test. So, this is going to assess how well he can hear. So, we're going to start, and you're going to repeat back to me whatever I say, okay?
34.
Okay.
65.
Okay, so he has good hearing with the whisper test, and then we can also do the Weber test. So what we want to do is we're going to put this tuning fork on the middle of his head, and he should have equal hearing on both sides of that, okay? Hearing on both sides? Okay. And then we're going to do the Rennes test to test his hearing. So this is where we put the end of the tuning fork on the mastoid bone, and if he hears it greater there, then he has some hearing loss because his bone conduction would be greater than his air conduction. So we're going to see where he hears this best at. 1 or 2? 2. Okay. And do the same thing on the other side. 2. Okay. So he has a normal hearing assessment. There are no issues with his hearing. His air conduction was greater than bone. We can also assess the nose. So in looking at the nose, it is symmetrical, and I can use my lovely little tool here. And I don't see any redness, any swelling, anything like that inside the nose. No drainage is present. I can assess patency on both sides of the nose. Breathe in. Breathe in. Okay. So it seems like he's more patent on this side than he is on this side, just based on hearing him breathe. So I can also palpate his sinuses once again. I already did. Any issues with that? Any pain? Okay. So that's the assessment of the nose, and then we can assess the mouth. So I can look and see that he has good hygiene, takes good care of his teeth, no issues there. His mucous membranes are moist, they are pink, they are not blue, so he's not cyanotic, he's not lacking in air right now. He has good adequate perfusion for the most part. So I can also assess his tongue strength with this lovely tongue blade. So I'm going to have you push against this with your tongue, which he's able to do. So he has good tongue strength, no problems there. And I can assess the neck and the throat now. So I'm palpating the trachea right now. And I don't feel any abnormalities. Trachea is midline, no deviation with that. I can also palpate his thyroid. He doesn't have a drink right now, but we're going to pretend he has a drink. So he's going to pretend take a drink and then swallow for me. Okay, so you assess one side at a time with the thyroid, and I don't feel any abnormalities with that. And then, once again, we can assess the lymph nodes in the neck. So we're just feeling, making sure that there's no inflammation or anything, any pain with that. Okay. So that concludes the assessment of that. So from there, we can assess the heart and lungs and thorax. So to assess the lungs, we're going to watch the rate of breathing, look at, the rhythm of breathing. Is he working hard to breathe? And right now he is not. He is very calm, comfortable, breathing about 16 times a minute, and he's not in any respiratory distress. If he was having labor breathing, anything like that, there would be some respiratory distress, cyanosis, he is blue, then we would know he's in some respiratory distress, obviously. He's got symmetrical chest wall movement, just looking at him breathe. One side's not more inflated than the other. He doesn't have a barrel chest, anything like that. So then I can go ahead and palpate his chest for subcutaneous emphysema. This would it would kind of sound like Rice Krispies, like whenever they pop. That's what it would sound like if you had subcutaneous emphysema. But he does not have that, so we are good there. I can also palpate tactile firmness, so I'm going to have him say the number 99 as I move my hands down his chest.
99. 99. 99. 99.
Okay, so in doing that, the vibrations on both sides of his chest were equal and symmetrical, which is a normal finding. If the vibrations were greater on one side than the other, then that would indicate some lung issues, maybe some consolidation, stuff like that. But this was a normal assessment of tactile firmness. So from there, we can go ahead and listen to lung sounds. Deep breath in and out. Okay, and I did not hear any adventitious lung sounds, no crackles, no rails, no bronchi, anything like that, so that was a good finding. If I did hear those, then obviously we'd have lung issues. So from there, I can have him turn to the side for me, because I'm going to listen to your back. There we go. Can you sit up straight for me? Good job. Okay, so same thing with the posterior side. We're going to assess lungs again. So we're going to palpate for subcutaneous emphysema, which I do not feel. I'm also going to do tactile firmness again, so I'm going to go ahead and have him say 99 again.
99. 99. 99. 99. 99.
Okay, and that was the vibrations on both sides of his chest were equal and symmetrical. I can also go ahead and check for diaphragmatic excursion. So what we're going to do is we're going to percuss the lungs. And so to begin with, I'm going to have you take a deep breath in, let it out, and then hold it. Okay, and hold that for me. Okay, so right there is where I heard some dullness. You go ahead and do that one more time for me. Okay, so right in there's where I heard dullness. Okay, go ahead and breathe normally for a second. Okay, and in just a second, I'm going to have you take a deep breath, and I'm going to have you hold it in for me, okay? Alright, so you're going to go ahead and do that now for me. And about right there is where I heard that, okay, you can go ahead and breathe normally. So about right there is where I heard the dullness, and so that right there is where I would mark my diaphragmatic excursion. And it should be about 3 to 6 centimeters. With athletes, it can sometimes be 7 to 8 because they have a better lung capacity than the average person. So I can also check the lung expansion. So what I'm going to have him do is take a good deep breath for me, and my hands should go apart. And they do. So lung expansion is great. I'm also going to go ahead and listen for the lung sound. So he's going to take some normal deep breaths for me. Okay, so no issues heard with that, no adventitious lung sounds from the back, so that is a normal finding. And so now we're going to go ahead and assess our heart, so I'll have him turn back around for me in the sitting position. Great. Okay, so first what we're going to do with our cardiac exams, we're going to go ahead and palpate the carotid pulse on each side. And with the carotid, you only want to palpate one side at a time, because if you palpate both sides at one time, then you could make the patient pass out. And we don't want that. And so he's already kind of reclined for me. If you could recline just a little bit more for me. Okay, so I'm going to have him pull that down a bit. Okay, so he's going to turn his head that way for me. And so what I'm going to measure here is the JVP. Gotta get my rulers. Okay, so we are going to palpate the JVP. So right here right there, his jugular. I can see it pulsating right here near the clavicle. And so what I'm going to do is I'm going to measure the angle at which that is palpating. So I measure from the point of pulsation to, and I'm going to put this on the chest wall. And in measuring that, it is about 2 centimeters. So in a normal patient, it should be no more than 3 centimeters. With patients who have cardiac insufficiency and that that pulsation is a little bit higher up than normal, then it can be increased. It can be 5, 6, and that would indicate cardiac dysfunction. So then I can go ahead and palpate for some areas. So I'm going to go ahead and palpate the apex of the heart. And he's just going to breathe normally for me. Okay, so that I'm palpating my PMI right now, which is my right there at the 4th and 5th intercostal space midclavicular line. So we palpated the PMI, and so now we're going to palpate for heaves. I'm just going to put my hand right in the center of his chest. Feeling for any heaves, and I do not feel any heaves or lifts. His heart's not beating out of his chest, anything like that. And I can go ahead and feel for some thrills at the 2nd intercostal space. And I don't feel any thrills with this patient, which if you did, that would indicate some cardiac issues. And vibrations, if you do feel vibrations, that's not abnormal. It's just they need to be felt on both sides. Then I can go ahead and auscultate my apical pulse for a minute. And we'll pretend we listen for a minute, and that's how you would auscultate the apical pulse. I can go ahead and also, I'm going to listen to the different points of the heart. So we're going to start with the apical, or the aortic, I'm sorry, the aortic. Pulmonic. Erb's point. Tricuspid. And mitral. And with that, I don't hear any abnormalities either, which is a good finding. From there, I can also use the bell of my stethoscope, and so I'm going to listen over the mitral and tricuspid valves, and we're going to listen for any bruits, which would indicate, or we can actually listen for bruits, murmurs, anything like that. And I don't hear any murmurs, anything like that. No S3, no extra heart sounds there. And like I said, we can listen for aortic stenosis over the aortic valve, and we would hear a bruit if it were present, and it is not in this patient. So then I can have this patient lay down really quickly. Just put your head that way for me. Great. We're going to go ahead and repeat our cardiac assessment, just listening again to all of these. Aortic, pulmonic, Erb's point, tricuspid, and mitral. And I don't hear any abnormalities with that either, so that is a normal finding. So go ahead and I'll have you just stay there for me, because we're going to go ahead and proceed with the abdominal portion of the assessment. I'm going to raise your shirt up, okay? Okay, great. So, I'm first going to be looking at the abdomen for symmetry. I'm going to be looking for scars, and he doesn't have any scars. Symmetry is great. I don't see any, like one side of his stomach is not more pronounced than the other. I don't see any evidence of hernias or anything like that. No striae or anything. So then I can also listen for bowel sounds. So I'm going to start in my right lower quadrant and work my way around. And so you're listening for active bowel sounds, and the patient does have positive bowel sounds. They're not hypoactive, they're not hyperactive, which is a good finding. And then I can use my bell of my stethoscope to listen for bruits, and so I'm going to go ahead and do that. We'll listen over the aorta. The inguinal. And femoral. And I don't hear any abnormalities there, so no bruits. And so from there, I can also percuss the liver. We can go ahead and we're just going to go ahead and percuss. So we're going to percuss from an area of resonance to an area of dullness, and from an area of dullness to an area of timpani. Or I'm pretty sure that's how it goes. Okay, so we're going to start here. So right there's where I started feeling some dullness, or hearing some dullness. Okay, and right there. So this right here would be our liver span if I measured it. And I didn't actually measure it, but if we were to measure that, that's what we're palpating. We're palpating liver span. And so it should be 6 to 12 centimeters. That's a normal finding. And then we can also palpate the liver edge. So I'm going to have him take in a deep breath and hold it, and I'm just going to palpate. And it looks like there's a little bit of tenderness there with that. Okay. So I could feel the liver edge. I didn't feel any abnormalities with that. It's nice, smooth, and symmetrical. I don't feel any part that's more so pronounced than the other. I can also do some light and deep palpation of the abdomen, so I'm just going to kind of gently press. Any tenderness with that? And then I can deeply palpate. Any tenderness with that? No? Okay. So that's great. That hurt? So no rebound tenderness. Obviously he's not guarding his abdomen. So then I can also percuss the spleen. So I'm going to percuss laterally from my left lower chest wall. And so I want to hear tympani, because if I didn't hear tympani, if I heard dullness, it could indicate some enlargement, and that would be a spleen issue. So I'm going to go ahead and palpate the spleen. And you may not always feel the spleen. That's not always possible. And that's also a normal finding. That's not abnormal by any means. So we can go ahead, and I'm going to have you sit up and turn around where your back was facing me again. And we're going to palpate for CVA tenderness. So I'm going to find my 12th rib on the spine, and the angle of the spine, and that angle is where we're going to assess for CVA tenderness. So, any pain?
No.
Any pain? No. Okay, so he didn't have any CVA tenderness. If he did, then that would indicate some kidney issues, possibly a kidney infection. I'm going to assess my peripheral vascular system. I'm going to look at the patient. Obviously, he's not cyanotic. I don't see anywhere where he is. We already looked at our mucous membranes earlier. He wasn't cyanotic in those either. I don't notice any edema anywhere in the patient, not in his legs, not in his arms, not anything, no facial edema, anything like that. So he has pretty good blood flow because he doesn't have edema. It's not pitting, anything like that. I can go ahead and assess my lymph nodes with that. I'm going to go ahead and assess my axillary lymph nodes. Any pain? No. Just ticklish, right? Yeah. Okay, and then I'm going to assess the epitrochlear lymph nodes. Any pain with that? No. And then I'm going to also assess the femoral lymph node. Any pain with that? No. Okay. So no pain. I can also check the pulses to verify that all his pulses are equal and strong bilaterally. So I'm going to go ahead and assess my radial, brachial, femoral, popliteal behind the knee, posterior tibial on the inside of the ankle, and then my dorsalis pedis on top of the foot. And all of those are strong and equal bilaterally. So pretty normal peripheral vascular assessment. From there, I can go ahead and assess the musculoskeletal system. I'm going to pause this and continue in the next video.